Newborn life support. In newborn life support, we need to first see the ABGAR score. ABGAR score stands for appearance, pulse, grimaces, activity, and respiratory efforts. In appearance, what we are looking for? We are basically looking for the skin color. What is the skin color? Is it normal skin color all over the body, or only in the extremities that is discoloration? That means it can be pale or it can be bluish in color, or it might be completely cyanotic and pale, the kit might be. So if the kit is completely pale or cyanotic, it carries 0. If it is normal except the extremities, then it is 1. Completely normal, then 2 points. These points, what I'm mentioning, might be changed in your blueprint. Please change it. Pulse. If the heart rate is more than 100, 2 points, less than 100, 1, absent, 0. Grimaces. Grimaces is the irritability or basically the expressions what you're looking for. For example, sneezing, coughing, or pulling away gets complete 2 marks. Just making some facial expressions gets 1 mark. No response at all gets 0 marks. Activity means is the muscle tone what we are talking about. If the kid is actively moving around, then the muscle tone is good. The arms or legs are fixed, but there are no active movements, what you're seeing, then gets in 1 mark. Completely absent, a floppy kid gets 0. Respiratory efforts are good and the baby starts crying. Crying is important because it helps to expand the chest. So the baby is crying and the respiratory efforts are good, then it gets 2 marks. No, the respiratory efforts are quite irregular. The baby is not crying loudly. At that point, it gets 1 point. Completely absent respiratory efforts gets 0. So this is calculated soon after the birth at 1 minute time duration. Then after 5 minutes, it is calculated. Whenever if a suspecting resuscitation is required, then then readily go for the resuscitation. Do not waste your time doing an ABGAR score. Resuscitation is done when the ABGAR score is less than 7. If it is 10, then it is a good score. Nothing needs to be done. You just repeat it after 5 minutes. That is enough. What if the score is between 7, 9, and 8? If the score is 7, 9, or 8, or 7, 8, or 9. At that point of time, you need to keep on repeating the ABGAR score every 5 minutes till it goes to the 10, where no registration will be required. You need not repeat the ABGAR score, or till it goes to less than 7, where registration will be required. So now we are talking about the newborn life support. In newborn life support is important. A question does appear in your exams. So first thing what you need to be aware is always ask for help. Help is important because you are not an neonatologist, so immediately seek for the help. Once you are asked for the help, then it starts here. Soon after the birth, you need to clamp the cord. Delay the cord as much as possible. That means delay the cord approximately for 1 minute if it is possible. Once you have cut the cord and clamped it, start the clock and note the time what is there. Dry and wrap the baby and stimulate and keep the baby warm. Dry, wrap, stimulate, and keep the baby warm. So you're stimulating the baby so that the baby cries if she has not cried. Make sure the baby is warm because you're dried and wrap. You're dried the kid, so it will be exposed to the external temperature, where the core body temperature might immediately come down because it is used to and warm environment in the mother's womb. So around 37 degrees, the baby is used to it. So external temperature will be around 24, 26, 27. So it will be drastic dip in the temperature. That's why you need to wrap it up and keep the baby warm. Then start the assessment. In assessment, we are not nothing doing, but it's an ABGAR score itself, what we have discussed. So you're looking for the color. What is the color of the baby? What is the muzzle tone of the baby? How is the breathing? How is the heart rate? These are the 4 things what we look out for in the assessment. If something is normal, abnormal, for example, the baby is floppy, the heart rate is less than 60, then no breathing efforts, the baby is completely cyanotic, then you need to start resuscitation. How do you start the resuscitation? First, you open the airway. So you ensure the airway is open. Once the airway is open, if the baby is not breathing or grasping, that will be the most of the time this will be the situation. Because of this, because of the respiratory efforts only, all the complications comes up. You need to give 5 inflation breaths. 5 inflation breaths are given only using the normal room air. You're not using any supplementary oxygen here. If the devices are available, then you can use a PEEP of 5 to 6 centimeters of water if possible. Most of the time it will not be possible in the ED department, and use an 3-lead ECG along with the pulse oximetry to measure the SpO2 values and monitor the rhythm what is there. Once you give the 5 inflation breaths, immediately assess for the heart rate. Has the heart rate increased, or not. If the heart rate is not increased, immediately look at the chest movements. Are the chest movements present or not? If the chest movements are not present, what do you need to do? See whether the mask it is making a good seal or not. If it's not making a good seal, make sure it is a good seal. If that is not working or good seal is already present, then use or optimize the head and jaw position so that the airway opens up. You have optimized, but still chest rise is not seen, then use the 2% technique. If 2% technique also fails for the chest raise, that's when you open the mouth and see any secretions are there and suction it out. If required, you will be placing the laryngeal mask or tracheal tube. Repeat the inflation breaths. Okay, if this also not required, most of the time advanced airways like tracheal tube will be helpful. So you're not going to the next step till you notice and chest raise. Chest raise is important. If chest raise is not present, that means the air is not entering into the lungs. If the air is not entering into the lungs, you cannot give the fine inflation breaths. So chest movement, the chest raise is very important. Once the chest raise is present, then only you can go to the next step. If the chest raise is present, okay, what you do next? Once chest movement are present, still the heart rate is on the lower side. That means the heart rate is less than 60 beats per minute. At that point of time, what you will be doing is you will be giving continuous breaths for 30 seconds. So 30 seconds you will be ventilating the kid. Even after 30 seconds of ventilation of the kid, if the heart rate remains less than 60, that's when you start the CPR. Here, the CPR ratio is different from the pediatric age group, where in pediatric age group, we used to do 15 is to 2. This is not the case in newborn. In newborn, it is 3 is to 2, 3 is to 1 ratio what we'll be doing. So 3 chest compressions to 1 ventilation what you'll be doing. Here, when you're giving a ventilation, you are giving with oxygen level of 100%. That means fraction of inhaled oxygen will be 100% here at this point of time. That is important. Consider intubation if it's already not done in previous steps. Laryngeal mask if it's not possible. If possible, place a laryngeal mask. If intubation is not possible, at least place a laryngeal mask. Reassess heart rate every 30 seconds. Chest movements and heart rate needs to be reassessed every 30 seconds. Usually we reassess after every 2 minutes. Here we are reassessing after every 30 seconds you are reassessing. If the heart rate remains undetectable less than 60 after one cycle, that is after 30 seconds of 3 is to 1 ratio CPR, still the heart rate has not increased. At that point of time, you need to get an vascular access and start giving drugs. That is, start giving adrenaline they're talking about. Think of causes like pneumothorax or congenital abnormalities like congenital heart diseases might be present. The patient might be hypovolemic. So in hypovolemic shock, the kid might be. Those parameters you need to start thinking. We are expecting by now there will be the neonatologist who will take over the case. Beyond this, it is out of scope of the emergency physicians. Next thing what you need to be aware of, what if the kid is preterm? Preterm means less than 32 weeks we are talking about here. If it is a full term or more than 32 weeks, we usually dry and wrap. Here it says do not dry. Okay, just plastic wrap and radiant heat needs to be used. Inspired oxygen, we usually use room air here. Here I said room air oxygen you will be giving. Here you are slightly increasing 21 to 30% or less than 28 weeks means around 30% you will be using it. Give inflammation breaths at and 25 centimeters of mercury, what is recommended if that is possible. Here it is 30 centimeters. Because it's a preterm, we want to give it a little bit less. That is 25 centimeters of water should be sufficient. Another thing, if you see in the algorithm, they mention the acceptable preductal SpO2. What is preductal SpO2? Preductal means this is the duct what they are talking about, ductus arteriosus. Preductal, this side what you will be having, this side what you have is the right arm. Left arm will be postductal. So this is the preductal. Right arm, sometimes left arm also can be preductal, but again, right arm mainly we are talking about. Right arm, if you are measuring the SpO2 values, at 2 minutes 65 is acceptable, at 5 minutes 85 and 10 minutes 90% is acceptable SpO2 values if you're using the right upper limb, right arm if you're using it. Let me recap it because it is very important. So what you do? What you do is first you will clamp it and delay it approximately by 1 minute if it is possible. Then you'll start the clock, dry and wrap and stimulate and keep the baby warm. Then you immediately start assessing for color, tone, breathing and heart rate. If anything of this is abnormal, for example, the kid is pale or the kid is floppy or rigid or there is no respiratory efforts or the heart rate is on the lower side or the respiratory efforts are quite irregular, then you give the 5 inflation breaths. Fine inflation breaths are given at room air. That is important. At room air, the fine inflation breaths are given. Once you give the fire inflation breaths, you immediately assess for the heart rate. If the heart rate remains less than 60 at this point of time, you need to see whether there was chest movement when I gave the inflation breaths. If no, check for the mask. If nostril is fine, check for the position. If position is fine, do an 2% technique. If 2% technique is fine, do an oral suctioning if there are suctions. If that is also fine, then go for advanced airway like in supraglottic airway devices, or you can go for entracheal intubation. That should raise the chest. Once chest movements are appreciated, then again what you'll be doing is you will be assessing for the heart rate. If the heart rate remains less than 60 still, then continuous ventilations you will be giving for 30 seconds. Even after continuous ventilation for 30 seconds, if the heart rate remains less than 60, what you will be doing? You will be starting at chest compression at 3:1. Here, the oxygen what you're giving for the ventilation goes up to 100%. The FiO2 goes up to 100%. That is important. Then again, you will be reassessing after 30 seconds. After 30 seconds, when you are reassessing, still, if the heart rate remains less than 60, what you'll be doing is this is point where you will go for an IV access. IV access is preferred. Do not give it through the duct. It is always preferred to give it through the IV. So not duct, do not give it through the umbilical cord. It is always preferred give it the IV access. If IV access is difficult at that point of time, you can go for an IO access also. Drugs like adrenaline we are talking about, start giving it. Start thinking of causes like pneumothorax, hypovolemia, and congenital abnormalities. These are the things what you need to be worried about, and up to here is what will be tested in the exam. After this, it's out of scope of the emergency vision. Here, where we are expecting the neonatologist to intervene. The change if the baby is preterm is we are not drying the baby. That is the important thing. We are slightly using on the higher side the FiO2 values. Room air is around 21%. Here, we are using around 30%. What you need to be aware of. Remember, first step is always to call help. Do not forget this. Shock. Shock means if the oxygen is not delivered enough to the end organ and doesn't meet the demand, then we call it as a shock. Keep it very simple. The end organ is demanding for certain amount of oxygen. If that is not delivered to it, the patient goes in shock. As simple as that. The shock can be because of anemia. Anemia means the hemoglobin is on the lower side. That means the RBCs are on the lower side. RBCs are the vehicles to carry the oxygen. So can have a shock because of that. It might be because of the reduced cardiac output. It might be because of loss of intravascular volume. In that way, there are different types of shock. Hypovolemic shock is the loss of the fluid. It's mainly the loss of intravascular volume. It might be because of the burns, diabetic ketoacidosis. It might be a hemorrhage because of a trauma or GI bleed or a AAA rupture. It might be a GI loss like diarrhea and vomiting. It can be a distributive, where the fluid is distributed in the third space, seen very commonly in sepsis, neurogenic shock, and anaphylactic shock. It can be an obstruction to the venous return. Okay, that means IVC, inferior or superior vena cava obstructions, it might be. Okay, or it might be because for the output. The venous return will be hampered in tension pneumothorax because the intrathoracic pressure is so much. So the movement will be from high pressure to the low pressure. So there will be quite low pressure in your limbs. So the venous return to the heart will be hampered in tension pneumothorax. That's why they will be hypotensive and go into the shock. PE. PE will what happen? The blood which is pumped from the right heart will not reach the lungs because there is a clot which is present. Okay, if it doesn't reach the lungs, it will not reach to the left atria, it will not reach to the left ventricle. So all your end organs will be suffering here, resulting in a shock. Cardiac tamponade. What happens in cardiac tamponade? There is a fluid around the heart which is present there. The heart cannot really expand and pump. The chambers, especially the ventricles, getting compressed. So goes into the shock. Acute obstruction of this, that is the superior or inferior vena cava, will also result in an obstructive shock. Cardiogenic shock. There is something wrong with the cardiac muscle. So it might be infarction, contusion, it might be inflammation of the myocardium, it might be an electrolyte, it might be an conduction abnormalities, something wrong with the electrical activity like arrhythmias, it can be resulting in cardiogenic shock. But you must have noticed here sepsis is present in distributive shock. Distributive shock, and sepsis is also present in cardiogenic shock. Most of the time, what happens whenever the sepsis is there, or in many other causes also, it can have multiple causes. It can have an distributive as well as cardiogenic. It can be an obstructive as well as an hypovolemic. So combination can also be existing. Classical example is sepsis, where because of the increase in the inflammatory markers, because of the severe infection, it has a negative inotropic and chromotropic effect on the heart. That's why you have a cardiogenic shock in late sepsis when the sepsis is quite severe. Anaphylaxis. Important topic. Once again, a question does appear from anaphylaxis, so you need to be aware of. So what you will be doing initially in anaphylaxis, you do not know whether it is an anaphylaxis or not. So the algorithm starts with, is it an anaphylaxis or not? How do you know? You do an A, B, C, D, E assessment. And what are you looking out for? You're looking out for, is there a trigger agent? That is important. Is there a trigger agent present or not? More than one system is involved. That is important. More than one system is involved. For example, there is a rash present along with the patient is having breathing difficulty. So two systems are involved here. The patient might be hypertensive along with has and rash. Two systems are involved here. It might be breathing difficulty and hypertensive. Two systems are involved. If more than one system is involved, there's two or more systems are involved, then you call it as an anaphylaxis. Most of the time, skin changes will be present. Once you suspect it is an anaphylaxis, you immediately call for help. Okay, it might be a resuscitation team or ambulance. Then, if you know what is the triggering agent, it might be the antibiotic what you are given, and the antibiotic is still ongoing. IV infusion, still IV infusion. Stop that IV infusion immediately. It might be an honeybee bite. If there is a sting present, remove the sting immediately. Then, important thing is to how to place the patient. Ideally, you want the patient to be in supine position. Sometimes supine position might not be the ideal position, especially the patient is short of breath. He is having breathing difficulty. At that time, propped up position might be the ideal position. If it is a pregnant lady, as we have discussed in an cardiac arrest due to the pregnancy, we always place them in the left lateral position. So any pregnant lady with more than 20 weeks of gestation is in the resuscitation B. We always place in the left lateral position so that the venous return is restored, so that the IVC is not compressed. That you need to remember. It is an universal thing. Once you're positioned, next thing is you give the intramuscular adrenaline. That will be the first thing. Give the intramuscular adrenaline will be given. At what site you will be giving? That is important. It is given intramuscularly in the anterolateral aspect of the thigh, what you'll be giving. Then what you'll be doing? This is the first dose of IM adrenaline what you are given. Once you give first dose of IM adrenaline, then in the meantime, you will be waiting for 5 minutes. Once you're waiting for the 5 minutes, in that 5 minutes, is the airway patent? How is the oxygen of the patient? Start connect to the ECG monitor, check the blood pressure, pulse oximetry, and supplementary support will be given. For example, the patient is hypoxic, give high flow oxygen. The patient is hypertensive, start on the IV fluids. That is important. 5 minutes are up. Still, the patient is not improving. At that point of time, you give second dose of IM adrenaline. You give the second dose of IM adrenaline. If you're not started with the fluid bolus, start with the fluid bolus at least here. There are plenty of fluids, as large as 2 to 3 liters of fluid usually will be required in a full-blown anaphylactic reaction. In spite of giving 2 doses of IM adrenaline, still the patient has not improved. Then what you need to consider? You need to consider this as to be a refractory anaphylaxis. Once it is a refractory anaphylaxis, you enter in this algorithm for refractive anaphylaxis. In refractive anaphylaxis, seek for the expert help if you're not already asked for the help. The first step is, do not get confused here. The first step is start the adrenaline infusion. That is the first step. The problem here is you can ask the nurse to start the adrenaline infusion. Can the nurse immediately start the adrenaline infusion? It takes time. She has to go and load. She has to break down multiple ampoules, load it and connect to the infusion pump, then start the infusion. It takes time. So what is the first step? You're asking the nurse to start the adrenaline infusion, but it will not be immediately started because it takes time for the nurse to do. In the meanwhile, what you're supposed to do? The second step is give one more bolus of IV fluid. Okay, boluses, when I talk about it, is around 500 to 1000 ml what we are giving the boluses. So one more bolus of 500 ml what we'll be giving here. It takes time, as I told you, to the infusion. If it is taking a time more than 5 minutes, you can keep on giving IM adrenaline every 5 minutes. Every 5 minutes, keep on giving adrenaline, adrenaline, adrenaline. If high flow oxygen is required, start them. You're targeting the saturations to be maintained around 94 to 98%. If the high flow or the oxygen supplement is not given, start them if required. Collect the blood samples, especially for mast cell trip test. We'll be talking about in coming up slides. Then what we do? Now you keep on giving adrenaline in between. You have 5 minutes infusion you have asked for. What you'll be doing? Do an ABC assessment. In ABC assessment, if you feel the upper airway has a partial obstruction, whenever there is a partial obstruction, whenever there is a narrowing of the trachea, a visual like sound will come up. This is known as stridor. So stridor is one of the sounds which is highly suggestive of an upper airway obstruction, a partial upper airway obstruction. Cue the adrenaline nebulization at that point of time. Total upper airway obstruction, then you need to follow the difficult airway algorithm and try to secure the airway, which you'll be studying in the anesthesia chapter. Breathing. In breathing, what we are saying is the patient having breathing efforts or not. If the patient doesn't have the breathing efforts, then you have to push the air inside the lungs. That's when you will start using an bag mask ventilation and consider going for an advanced airway. No, this is a severe bronchospasm the patient is having. That's when you will go ahead with salbutamol and ipratropium bromide. These nebulizations are driven with the oxygen, what you need to be aware of. If required, you can give IV salbutamol also. Circulation. If the patient is still hypertensive, you can give more and more boluses. The fluid which is preferred is either the Hartmann solution you can give, or plasma light can be given, or RL can be given. If these are not available, you can also give NS also. I said 2 to 3 liters. You can see here, volume like 3 to 5 liters in an adult is required. So that's why we are mentioning multiple places. For example, I have mentioned about the IV fluid bolus here. Next slide, I have mentioned about the IV fluid bolus again here. In the another slide, I have mentioned here IV fluids here. So 3 places we are telling that give boluses, because this full-blown anaphylactic reaction usually will require around 3 to 5 liters of fluid in an adult patient. If someone is not responding even for an adrenaline infusion, then you can start other infusions also, like a noradrenaline or vasopressin can be started. If the patient is on beta blocker, consider giving glucagon. Okay. For example, he's taking beta blocker for his AF, or he's taking beta blocker to control his blood pressure, then glucagon will be required. They may not be very effective to the adrenaline what you're giving. In spite of giving adrenaline infusion, in spite of adding other infusions also, if the patient is not responding, then the only option will be left is with the ECMO, extracorporeal left support. Is there any changes in the cardiac arrest algorithm? Absolutely no changes. That means adrenaline, you need to give it. How you are giving it? IV boluses here. Infusion, you need to stop it if they go into cardiac arrest. Give IV boluses if they remain in PEA or an asystole. If they remain in shockable rhythm, then you will be giving them the shock. So you are absolutely following the ALS algorithm. There are absolutely no changes. Do not get confused. Do I need to give an IM adrenaline or an IV? There are absolutely no changes. That means you are giving IM adrenaline. Do I need to continue the infusion? No, infusion is not required because you're giving boluses of IV adrenaline here. One more thing, you can see here IV bolus. Okay, IV bolus can be given if you're skilled enough to give it. This is kind of reserved for a consultant level or for an consultant anesthetic rather than for an emergency physician at a registrar level. Doses are important. Adult or child more than 12 years is 500 mics. IM again, it's all IM. The dilution is important. It is 1:1000 dilution what you're giving here. 6 to 12 years of age group, 300 mics. 6 months to 6 years, 150 mics. Less than 6 months, 100 to 150 mics, what you'll be giving in that range. Boluses in children is 10 ml per kg. In adults, it's 500 to 1000 ml, what you're talking about. So do not get confused here. That's why I'm repeating here. Step 1, as I told you, is the adrenaline infusion. Step 2 is giving the IV fluid boluses. Step 3 is giving IM adrenaline. If the infusion, starting of the infusion is getting delayed for more than 5 minutes, then you're giving IM adrenaline. You can continue giving IM adrenaline every 5 minutes. Then comes the ABC assessment. Master trip test. This kind of helps you to say that yes, this was an anaphylaxis. Otherwise, no investigation is required for the diagnosis of an anaphylaxis. It is completely an clinical diagnosis. So as soon as possible, collect the blood sample for a master trip test level. Then again, you will be repeating after 1 to 2 hours. Then again, you will be repeating after 24 hours. It is collected in a normal UNE bottles you will be collecting. If the patient is on a beta blocker, as said before, consider giving glucagon for those patients. Most of the patients are observed for 6 to 12 hours, but fast tracking is there. I will be talking about in coming up slides. Now, next one is what is biphasic reaction? Biphasic reaction is a patient had an anaphylaxis and he recovered completely. So he had anaphylaxis, he recovered completely. After few hours, again he develops the anaphylaxis. Again he is developing anaphylaxis. This is known as biphasic reaction. For the worry of this biphasic reaction only, we want this patient to be observed for a longer duration. What are the risk factors for a patient to have an biphasic reaction? The risk factors to have an biphasic reactions are severe initial presentation of anaphylaxis. That means multiple systems are involved. A respiratory, he is in respiratory arrest, he is in cardiac arrest, so just severe involvement. Or he might be severely hypertensive, the saturation is on the lower side, requiring an intubation. Okay, those are high risk for biphasic reaction. Initially, it required more than one dose of adrenaline to reverse the effects what the patient had. Or administration of the adrenaline got delayed. Delayed means at least delay by 30 minutes, then we call it as a delay. So at least consider 30 minutes. Within 30 minutes, if you're given, it is not considered as a delay. History of previous biphasic reactions. If any one of this following is present, then they become an high risk for an biphasic reaction. As I told you, we need to observe. Okay, we can fast track for 2 hours. If all these four criteria are satisfied, let's see what is the four criteria. First criteria is there should be a good response. Okay, so within the adrenaline dose, what you are given, and it is given within the 30 minutes, and patient kind of rapidly responded to it. So rapidly responded that he came back to his baseline. He completely resolved. There are no symptoms. Along with it, the patient already have as an EpiPen, which is also known as adrenaline auto injector, and he knows how to use it. Along with it, there is an adult who can supervise him after the discharge. If all of this four, that means he has very well responded to the adrenaline dose what you are given, and the adrenaline dose was given immediately, and the patient has an EpiPen, and someone is there to supervise him. If all these four are present, you can just observe for 2 hours. This is known as fast track. Most of the time, we do not do an fast track. Most of the time, all four criteria will not be present. We need to observe minimum of 6 hours. Okay. What if the fast track is not possible because any one of this following is not present? Then 6 hours you are observing for. Minimum of 6 hours if two doses are used or previous history of biphasic reaction are there. Minimum of 12 hours observation if you have to do. Severe reaction requiring more than two doses. Here, two doses. Here, more than two. That means three or more we are talking about. Patient has a severe asthma or there is a severe any lung disorder is present. For example, severe asthma and all. They are responding, especially in severe asthma, they're responding to an anaphylactic reaction is very difficult. If they respond also, you need to observe for 12 hours. They are very at high risk to have an biphasic or deterioration is very much possible in this individual. Possible continuation of absorption of allergen. That is the triggering agent. For example, a sustained release tablet he has taken, which releases the medication over and 6 hours duration. Then you need to admit that at least for 12 hours. It is a late night. Okay, the patient may not be able to respond to any deterioration. Is the elderly person. This is mainly the social reason what we are talking about. We need to consider that one. Admit it if it's a late night. Patient in areas where access of emergency care is difficult. He lives somewhere far away where there are no houses in the vicinity. Ambulance takes more than half an hour to reach that vicinity. At that point of time, I did my patient because if he has a biphasic reaction, he may not be able to come back to the ED department within the concise time. Prescription of adrenaline auto-injector is always appropriate to give it unless it is a drug-induced reaction the patient is having. You give it. If it's a drug-induced reaction, he has to take it or he might get exposed again. At that point of time, yes, again, adrenaline auto-injector, that is nothing but EpiPen will be required. EpiPen usually comes in what doses? It comes in three doses. It can be 0.5 mg or 0.3 mg. Nowadays, it is coming in 0.5 mg also, EpiPen. What are the common causes for anaphylaxis, like an peanut or tree nut or cow's milk? Medications wise, mainly the antibiotic, the penicillin, cephalosporins. It can be neuromuscular blocking agents like N-succinylcholine. It can be or rocuronium or etracuronium can be contrast media which you use for scanning, like a CT scan with an IV contrast. That contrast media I'm talking about. NSIDs can cause an anaphylaxis, especially the Diclofenac is very much prone for anaphylaxis in certain areas. The adrenaline auto-injector, also known as EpiPen, okay, this can cause severe vasoconstriction and ischemia, especially if you just inject it over your extremities. Instead of injecting over the anterolateral aspect of the thigh, you're just injected over the extremities. If you're injecting over the extremities, it can cause severe vasoconstriction. Okay, that you need to be aware of. Severe vasoconstriction can result in severe ischemia, so reduced sensation, pale, and severe pain they can develop. How do you manage if the patient has by mistake injected, or some kid has taken his father's EpiPen and injected over his arm, or the kid didn't know how to use it and injected over the finger, and has a severe vasoconstriction resulting in severe ischemia? So first, what you do is immerse in the warm water. See whether it is effective or not. If it is not effective, IV infusion of iloprost, that is an prostaglandin analog, is preferred. Still not effective, then immediately involve the vascular surgeon. Vascular surgeon advice needs to be taken. A local injection of phenterlamine works well. The problem is it is not available in the UK. What is anaphylactoid reaction? It is very much similar to anaphylaxis. The treatment of anaphylactoid reaction is nothing but like an anaphylaxis itself. The pathophysiology is different here. The triggering agent, a prior exposure to the triggering agent should be present for an anaphylaxis. For an anaphylactoid reaction, prior exposure to the triggering agent is not required. That is the important differentiating factor. The treatment is similar to anaphylaxis. The characteristic presentation is similar to the anaphylaxis. But the triggering agent, the previous exposure is not required. Occurs after the re-exposure to the antigen. There is a triggering agent. Is required for anaphylaxis. It is not required for an anaphylactoid reaction. It can occur with the first exposure itself. The classical example is the contrast media, what we use it for the scan. Here, the classical example is like insect bite or an snake venom or an antibiotics. Angioedema. Angioedema is kind of very much similar to urticaria. The differentiating factor here is urticaria just involves the epidermis most of the time. Okay. Angioedema, it involves the much deeper layers. So deeper dermal layer, it involves subcutaneous tissue and submucosal tissue it involves. Okay. And it is anatomically localized. This is a classical example of the articarial rash what the patient is having. Here you can see here anatomically localized most of the time around the lips. It is quite deep. That's why you can see obviously enlarged lips. This is suggestive of an angioedema. Angioedema can be an allergic form or it can be a non-allergic form angioedema. Allergic form is mainly mediated by an histamine. Non-allergic form again can be because of drugs like an ACE inhibitors. This is because of bradykinin. This inhibits the degradation of bradykinin. This is a bradykinin mediated angioedema. Hereditary is also bradykinin mediated angioedema. Here, what happens is inherited mutation is present. C1 esterase inhibitor deficiency is present in these individuals. So remember, C1 esterase inhibitor. Everyone forgets the inhibitor. You cannot forget C1 esterase deficiency. No, it's not C1 esterase deficiency. It isn't C1 esterase inhibitor deficiency. That you need to remember, which is very important. What are the acquired causes? Chronic disorders, what we are talking about, like an autoimmune, chronic illnesses we are talking about, like an autoimmune disorders, what we are talking about, or an autoantibodies against C1 esterase inhibitor. These both are kind of mediated with both, that means drug or hereditary or acquired angioedema, all are mediated by bradykinin. There might be an unknown cause. It might be idiopathic. We do not know the exact cause at all. It might be pseudo-allergenic. Pseudo-allergenic classical example is NSIDs. Do not forget. What are the drugs? We already learned about ACE inhibitors and NSIDs. Can other drugs? Yes, like vaccines, SSRIs, can be an angiotensin antagonist or a PPI, especially an omeprazole, can cause angioedemas. All these drugs can cause angioedema. How to differentiate between an allergic and a non-allergic angioedema compared to that of an anaphylaxis also? Anaphylaxis, as I told you, it is an hyperacute presentation what the patient will be having. Very hyperacute presentation, and two systems at least will be involved here. That is not the case. It is anatomically localized positions like around the lips, a tongue, mouth swelling, what will be present here. So anatomically localized attack in both allergic as well as non-allergic angioedema because it's an angioedema. When it is a non-allergic angioedema, most of the time it is a gradual onset. Allergic angioedemas are the acute onset what they will be having. Allergic angioedemas are associated with itching, and the blood pressure will be in the normal range. Non-allergic angioedemas are the ones which will not be associated with the itching. Usually previous episodes, similar episodes will be there, and most of the time abdominal pain will be present. Because it is an angioedema, this patient also will be normotensive. The blood pressure will be in the normal range. Remember, urticaria and itching more suggestive of an allergic. Absence of itching, absence of urticaria is more suggestive of a non-allergic angioedema, and usually they are in gradual in onset. What is the treatment? Allergic angioedemas. If it is quite severe, you're suspecting there might be an impending airway compromise, we go ahead and give them an IM adrenaline and treat it like an anaphylaxis. If they are not having, it is quite mild, this is some swelling, we're not suspecting an airway obstruction here. In those situations, it is an allergic mediated by histamine. So we give histamine blockers. Both histamine receptors, that is H1 and H2 receptors, are blocked. H1 receptors blockers are nothing but antihistamines like and chlorpheramine, formamine, cetirizine you can use, fexofenadate you can use. H2 blockers. H2 blockers are nothing but ranitidine, cimetidine, which are common drugs which you use it to reduce the gastric secretion. Systemic corticosteroids can be given in this individual. Topical corticosteroids have no values, do not give them at all. If it's an hereditary or drug-induced or an acquired angioedema, they are having it. The first drug of choice is, or first thing what you'll be doing, this is the first drug of choice, is C1 esterase inhibitor concentrate. If that is not given in the option, look for an FFP, fresh frozen plasmas. So this becomes the second one. If that is also not given, then you're looking for the third option, that is bradykinin 2 antagonist. Idiopathic or pseudoallergenic, then it's a supportive management itself. We do not have anything specific for idiopathic or pseudoallergenic. Last topic is urticaria. Urticaria, we already know it just involves the epidermis and it is a mild presentation most of the time. If you know the trigger agent which has caused this is a mild, for example, is use of a new soap or a new deodorant, you have used it, you come across an pet animal like a cat, or you come across some sheep you must have come across, or you are used and you had something which is new, which is abnormal for you, like you had an sushi or you had some seafoods which are very prone for an urticaria. So known trigger and mild symptoms, do not give any symptoms, do not give any treatment here. Just tell them to avoid the trigger because you know the trigger. If you do not know the trigger, also no treatment itself it will be. If it's a moderate symptoms, quite a bit of itching is there, he's uncomfortable here, he's seeking for some medications, then you'll be giving antihistamines. Any antihistamines can be given, but the preferred one will be non-sedative antihistamines. We do not want to sedate him. Why do you want to sedate him? So the first generation of antihistamines are not preferred. It's the second generation that is non-sedative antihistamines are preferred. Like like cetirizine, loratadine, fexofenadate can be given. You can prescribe them up to 6 weeks also. Severe symptoms. Severe symptoms are the one who are come in, you prescribe them antihistamines, but antihistamines are not effective. At that time, you can start them on systemic steroids like prednisone 40 mg for 7 days can be prescribed. Which is the antihistamine which is preferred in breastfeeding? In breastfeeding, loratadine or cetirizine are preferred. In pregnancy, we tend to avoid all the medications, including the antihistamines are not preferred. But they are forcing you to choose an option. They are not given, do not prescribe anything. They are not given, avoid. At that point of time, choose loratadine. Ideally, avoid, do not give any medications. No, they are not given anything. They are all mentioned the antihistamines. At that point of time, only you loratadine. The most common drugs causing urticaria are like penicillin, aspirin, NSAIDs, and vaccination. Most likely food which causes an urticaria are milk, eggs, peanuts, tree nuts, and shellfish. Like milk, eggs, peanuts, tree nuts, and shellfish. Usually, urticaria is associated with certain amount of itching will be present in this individual. So, anyone has any questions, you can ask me before we enter into the question and answer sessions. So, basically, we'll be discussing of plenty of question and answer sessions. One point I want you to again emphasize, or I want to add up basically here is the position. I told you anterior lateral. Second dose where we'll be giving. Give it in another position. For example, right anterior lateral part of the thigh you are given first dose. Second dose will be given on the left anterior lateral part of the thigh. So you'll be interchanging the sites what you'll be giving. Do not give all the doses on the one limb itself. Interchange. Do not give the same limb itself. That is the one thing I wanted to add up, which I had not add up when I was talking about. Anyone has any questions? You can ask me before we start. All right, we'll start discussing here. I do not see anyone has put up any questions, so we'll be start discussing the questions here. The first one is a 45 years old individual who has come to the emergency department. Okay, emergency department was found unresponsive. Okay, nurse checks the temperature and tells you it's in 28 degrees Celsius, and you already started, according to the ALS algorithm, you already started resuscitating the patient. Okay, so what are we trying to do? Or which one of the following is true, they are asking. For the modification of standard ALS guidelines is recommended. So this patient is hypothermic. This patient is hypothermic. What is the standard ALS guidelines is recommended? They are asking. So standard ALS, no shock are to be given till the temperature is 30. No, you can give 3 shocks. Doesn't matter what the core body temperature is. The fourth shock, when you are giving it, it should be more than 30 degrees Celsius. Adrenaline is to be given when the temperature is more than or equal to 30 degrees Celsius. Yes, that is the right statement. So you'll be giving at 30 or more than 30 degrees Celsius, you'll start giving the adrenaline. Up to 30 to 35 degrees Celsius, double the duration you'll be giving. Adrenaline is to be given when the temperature is less than 30. No, withhold the drugs less than 30. So it is a wrong statement. Check central pulse for 10 seconds before declaring death. It is not 10 seconds, it's 1 minute before declaring the death. Give adrenaline if the temperature is less than 30 degrees Celsius. No, we have to withhold the drugs as mentioned here. A patient has come to the MS department complaining of dizziness, denies any chest pain or syncope. The vital parameters is stable except the heart rate being 220. What is the next best step they are asking? First thing what we need to do, they have given us the ECG. We need to have a look at the ECG. What does the ECG says? ECG says it is in polymorphic ventricular tachycardia. That means it is in broad QRS complex polymorphic ventricular tachycardia. The next question is the patient stable or unstable? What we are asking about. Okay, is the patient stable? That means is the patient having a life-threatening feature? So the correct terminology is the patient having life-threatening features? No, there is no syncope. The patient is not in shock, doesn't have any decreased CNS supply, blood supply is present, or the patient doesn't have a myocardial infarction. So what are we thinking about? It is unstable or no life-threatening features are there, but it is a polymorphic ventricular tachycardia. So the drug of choice here will be to give magnesium sulfate 2 grams. That is the drug of choice. A kid is weighing around 12 kgs. He's in cardiac arrest. This is the rhythm what they are given. You want to shock it. What will be the energy? In cardiac arrest is 4 joules per kg. 12 it is mentioned. So 12 into 4 you are having 48. 48 settings will not be there. It is in the increment of 5 what will be having in the defibrillator. 45. So 45 to 50 to 55 to 60. In this manner it will be present. So we need to round it off. 48 joules will be closer to 50. So the right answer is the 50. Is the patient in cardiac arrest? Yes, that's why we are giving asynchronized. If the patient is not in cardiac arrest, but he has this rhythm and life-threatening features are there, then we give always synchronized shock. Only in cardiac arrest, we give asynchronized shock. An elderly female came to the emergency department complaining of lightheadedness. Heart rate is on the lower side. Blood pressure is also on the lower side. Atropine 3 mg was given and non-adrenaline infusion is started. What is the next best step they are asking? Next best step here is, doesn't matter what is the ECG is. A bradycardic patient having a life-threatening feature like the patient is having a shock here. What we do, we need to intervene. They have intervened with atropine. They have started on the infusion, still not. External pacing. External transcutaneous pacing will be the best. What if I change a little bit this question and remove non-adrenaline infusion is not started? I remove it off. Still the right answer will be transcutaneous pacing. Transcutaneous pacing is preferred over any other infusion. Atropine we are not giving more because maximum dose is 3 mg which we have already given here. 80 years old individual complains with swollen tongue as shown in the picture. His regular medications includes amlodipine, ramipril, and atorvastatin. There is no recent change in medications at all. What is the most likely diagnosis they are asking? You need to remember that if the patient is on, for example, a drug like an ACE inhibitor, he might be on years for these medications. After years, he can still develop an angioedema. It is not always required. It has to be acute. If it is acute onset, a new drug has been started and he had it, it's the most likely cause. It's not the new drug, but he's taking for the longer duration. Can still it cause an angioedema? Yes, it can still cause an angioedema. That's why I'm picking it up as an ACE inhibitor induced angioedemas. If it is an hereditary angioedema, by 80 years, he should have had few more episodes. Acquired angioedemas are seen in chronic disorders like autoimmune disorders, which is not mentioned here. Anaphylaxis, two or more systems are involved. Arctic area, mainly the skin, what you're seeing, the raised erythematous rash, what you'll be seeing in Arctic area. 11 years old child collapsed. Collapse means loss of consciousness. That means decreased CNS blood supply. That means this is a life-threatening feature. Jesus is also on the lower side. What is the initial treatment? ECG is suggestive of an polymorphic ventricular tachycardia. Along with the life-threatening feature, I need to shock him. Is he in the cardiac arrest? No, he's not in the cardiac arrest. So I need to shock. Synchronized shock needs to be given. So synchronized shock is the right answer. It is a pediatric age group. So we give 1 joule per kg here in the pediatric age group. Young male has come in with an history of syncope, conscious and complaints of palpitations in the ED department. ECG is provided here. What does the ECG says? In ECG, I can see there are PVCs which are 3 or more PVCs consecutively present, followed by a sinus rhythm. This is known as non-sustained ventricular tachycardia. If you're having a non-sustained ventricular tachycardia, the best treatment is to treat the underlying cause. If the patient is stable, if the patient is unstable, that's when we plan to shock the patient. Here, there is not much history which is mentioned, which is suggestive of the patient is unstable. Okay. History of syncope. We're not seeing the life-threatening features. We're not following the ALS algorithm here. So syncope doesn't matter here. We're looking for the underlying cause. There are two underlying causes possible here. One is the magnesium being on the lower side. Another one is the potassium being on the lower side. Which one we are worried about? Magnesium. So give magnesium first. If it was an IV potassium as another option, still we choose magnesium as first. Always give magnesium first, then the potassium. We're worried about magnesium. Magnesium causes QT prolongation. That is the most life-threatening compared to the potassium. Again, potassium correction becomes resistance if the patient has an hypomagnesemia. So always magnesium should be corrected first. A 30 years old woman has presented with a severe breathing difficulty. She is a known case of asthma. So you're suspecting an acute exacerbation of asthma. She becomes unresponsive and there is no signs of life are present. That means the 30 years woman is in the cardiac arrest. What is the correct statement here? Okay, for an asthmatic patient who has gone into the cardiac arrest, what is the correct statement? Supraglottic airway will protect effectively ventilation during ventilation. Effective ventilation can be given during ventilation. No, supraglottic airway devices may not be effective in an asthmatic patient because of increased resistance. Increased resistance, the air might end up entering into the esophagus, may not enter into the lungs because of the increased resistance. That's why endotracheal tubes are preferred, not in supraglottic airway devices. Ventilation rate should be high. No. In asthma, what are we suspecting? Type 1 respiratory failure, not type 2 respiratory failure where you want to wash out the carbon dioxide. Again, a false statement. IV magnesium is contraindicated as it might worsen the hypertension. No, IV magnesium is actually preferred. It's not contraindicated. Bilateral pneumothorax can be ruled out using an X-ray. Only an X-ray cannot rule out. If you want to rule out, a CT scan needs to be got it done. Due to hyperinflation, higher energy of defibrillation might be required. Absolutely yes, because of presence of gas trapping. 8 years, that is the pediatric age group, has collapsed. 12 ECG was taken which showed an SVT, which is the most common tachycardia in children. If they ask tachycardia, it's a sinus tachycardia. If they ask arrhythmias, then it becomes an SVT in pediatric age group. If they ask arrhythmias in an adult, it becomes an AF. If they just ask in tachycardia, either it is an adult or a pediatric age group, it will always be sinus tachycardia. A 22 years old female complains of palpitations. The nurse is struggling to measure the blood pressure as the heart rate is high. What is the most appropriate next step they are asking? What is this? It is a narrow QRS complex. Regular we are having it. Seem to be heart rate more than 184. Definitely it is a supraventricular tachycardia. We have the rhythm here. Now the question is, the nurse is struggling to measure the blood pressure as the heart rate is on the higher side. So does this mean hypotensive? Yes, this means hypotension. Why does it mean hypotension? The blood pressure is so low that you're not able to measure it. It is an ideal situation. Don't think like the nurse might not be skilled enough. No, here, whatever they mentioned, everyone is quite skilled and they are like perfect with their skills, what you're expecting. We're not expecting anything like this is a student nurse. She may not be skilled enough. She may not know how to measure the blood pressure. We're not thinking in that manner at all. So what we'll be doing in this circumstance here, blood pressure we need to consider on the lower side. Life-threatening feature is present. Along with the tachycardia, we need to give an synchronized shock. So the right answer here is to give an synchronized shock. Unresponsive at home. As elderly person unresponsive at home, a 12-lead ECG was taken, which shows a third-degree AV block with a heart rate on the lower side, that is 34. You are given atropine, 3 mg not responded, transcutaneous pacing here started. Increase the current to 100 joules. Still monitor shows no electrical capture. What is the next best step? 100 joules. Maximum is around 120 to 130 joules. What we can do? We can increase the energy. So increase the current, increase the energy, increase the output. You have an 18-month-old kid who is choking. Child starts gasping and becomes unresponsive. Okay. We will also add up that pulse is present. What we do next? We need to follow the BLS. So you can see in this algorithm, unconsciousness is enough. Holds good for both adult and pediatric age group. We are not checking for the pulse. Okay, we're not checking for the respiratory efforts. We are just seeing whether the patient is unconscious or not. In other terms, if the patient is responsive or not. If you're suspecting an body inhalation and the patient becomes unresponsive or the patient becomes unconscious, then you start the BLS. Here in the pediatric age group, that's why 5 inflation or the rescue breaths will be given first, followed by the CPR in the ratio of 15:2. A 48 years old male is in cardiac arrest. What is the recommended compressions over a minute? It's a BLS straightforward question they are asking. It is it is 100 to 120 compressions per minute. What depth? Around 5 centimeters, not more than 6 centimeters. Infant lethargic and reduced responsiveness. Heart rate is 190 per minute. Blood pressure is on the lower side. Temperature is on the higher side. CRT is on the higher side. Most appropriate next step. The problem here, what you need to hear is, this looks like an SVT. I do agree it looks like an SVT here, but it is an infant. For infant, heart rate up to 220 is normal. If you see the algorithm here, the heart rate up to 220, you take it as normal. So, depending on the heart rate, we need to take it a call, whether it's a sinus tachycardia or an SVT. I say it is a sinus tachycardia because it's an infant and the heart rate, what they have mentioned, is 190. It is well below the 220 mark. So what do you need to do if it's a sinus tachycardia? We treat the underlying cause. What might be the underlying cause for the tachycardia the patient is having? The two underlying cause, he might be in septic shock, giving IV fluids will be helpful here, which is not mentioned in the options here. So the next one is he's having an high temperature, high core body temperature might cause tachycardias, usually causes tachycardias. So paracetamol becomes the most appropriate. If they given IV fluids, I would have selected IV fluids because I'm suspecting more like in shock, it will increase the blood pressure also. So I can treat two things simultaneously here by giving an IV fluids. I'm suspecting because of hypertension, there is a reflex tachycardia what the patient is having along with the high temperature. 30 years old pregnant lady has delivered in the emergency department. Newborn is handed over to you. On assessment, you notice that the newborn is not crying and breathing. What you do in the next step? In the next step is usually dry the baby. But if they are given call for help, can it be an right answer? Yes. Call for help would have been the right answer here. But that is not mentioned in the options. That's why, according to the newborn life support, what we do is we dry the baby. We dry the baby, wrap the baby, and stimulate the baby. This is one step. Here, dry and wrap and stimulate. But first, ask for help. That is most important step. First step always. A 37 years old pregnant lady. So she's pregnant. She has delivered in the emergency department. You notice that the baby is not breathing. You call for the help. Help is called already. They are mentioned. Start the watch clock. The baby is dried and wrapped in a clean cloth. What is the next best step? The next best step is to assess the color, tone, and reflexes. This is the next best step. This has been done. So the next best step will be, or the next step is to assess the color, tone, breathing, and heart rate. Nothing but Apgar score, what you're trying to do. A gross Apgar score. A 2 years old kid was playing in Lego. Severe breathlessness is complaining of. Kid is not responding, but a central pulse is present. What is the most appropriate next step? Doesn't matter if the pulse is present or not. suspected foreign body inhalation and the patient is not responding or unconscious, we start with a BLS. BLS says do give 5 rescue breaths first. A 5 years old baby was brought to the MS department by his mom. While having a dinner at home, suddenly the kid became distressed. Is having weak cry now. Most appropriate action. Weak cry, sudden distress is present. What are we suspecting? Foreign body inhalation. Once again, we are suspecting. So as it is a 5 years old, weak cry is present. That means effective cough is not there. If effective cough is not there, we go ahead with 5 blows and 5 abdominal thrust. If effective cough was present, then we would have encouraged the kid to cough. 10 years old boy, sudden onset of breathing difficulty while he was having dinner. You make a diagnosis of anaphylaxis, administer the adrenaline. What is the dose of adrenaline? What you'll be administrating this kit? And what is the ratio? Concentration. 1 is to 1000 concentration. Doesn't matter pediatric or adult age group. What is the dose? Dose 10 years old. 10 means between 6 to 12 years of age group. We give zero point 0.3 mg, also known as 300 max once and the same thing. If it is an adult or more than 12 years, 500 max. 6 months to 6 years, 150 max. So the right answer here is 0.3 mg IM, 1 is to 1000 dilution. What suppose the diagnosis of anaphylactide reaction as opposed to the anaphylactic reaction? Anaphylactic reaction requires a prior exposure to the antigen. Here, prior exposure to the antigen is not required. So the right answer here is no exposure to the antigen previously will be the most appropriate answer. A 19 years old male present to the ED department denies any chest pain or syncope. Blood pressure is in the normal range, but his heart rate is on the higher side. He's complaining of heart racing. Heart rate is on the higher side. Most appropriate next step. First question is there any life-threatening features? No. Next question is, what is the rhythm? Narrow QRS complex, regular rhythm, and heart rate is more than 180. I am considering as an supraventricular tachycardia. SVT. How do you treat an SVT, which is doesn't have an life-threatening features? By doing an vagal maneuver. If this fails to respond, then we give 6 mg. Fails to respond, 12 mg. Fails to respond, then we can give 18 mg IV. Fails to respond, we give an verapamil, that is a calcium channel blocker, or a beta blocker can be given. Fail to respond, then we give and shock, that is the synchronized shock. This is the algorithm what I said. What does a biphasic reaction means? Biphasic reaction means he had an anaphylactic reaction, completely recovered after few hours, had another anaphylactic reaction. That is relapse of shock after responding to the treatment. He was in anaphylactic shock, he responded to the treatment, then again he went into anaphylactic shock. That is a biphasic reaction. 65 years old, complaints of tongue swelling and lip swelling as shown in the image. GP has recently changed the hypertensive medications. Hemodynamically stable. What is the most likely diagnosis? Hypertensive medications changed, which might be it. The good guess is it might be an AC inhibitor. So it is an angioedema, more precisely, drug-induced angioedema. Yeah, just given an angioedema, so it becomes easier to answer here. An elderly female was found unresponsive at the residence. Neighbor started CPR immediately. Cardiac monitor was connected in the emergency department, which showed an asystole. When do you consider stopping in CPR? They are asking. You consider stopping CPR if the duration is more than 20 minutes. Along with it, there are no response for an intervention at all. Along with it, there is persistently low ETCO2 values, or there is an cardiac standstill on an ultrasound scan. Okay, on cardiac standstill on an ultrasound scan. So what we do is we look for the combination of this. Which one has the combination of this? Combination of this is present only in the option number 5. So that becomes the right answer here. A 72 years old has collapsed. On assessment, he is found to have a third degree heart block, 38 blood pressure is on the lower side. No response to the atropine. So he started the transcutaneous spacing at an output of 70 millivolts. Next best step they're asking. So we look at the rhythm what they're given. Is it an electrical capture present? No, because after this electrical activity, no QRS complex. After this electrical activity, no QRS complex. After this electrical activity, no QRS complex. Suggestive of no electrical capture. If there is no electrical capture, what will be doing? Increase the pacing current. So the right answer here is the pacing current increase. Up to maximum you will be increasing, that is 120 to 130 joules. In spite of this, still there is no electrical or mechanical capture. That's when you change the pad position to anterior posterior. 62 years old female brought to the ED department with an episode of syncope. Third degree heart block with an heart rate of 36 and blood pressure of 82 by 42 is present. There is no response to the atropine, hence comments on transcutaneous pacing, and you reach the maximum current. What is the next best step? Reach to the maximum, but still there is no electrical capture which is present according to the resistance report is given. What you need to do is change the pad position to an anterior posterior position. A junior doctor, he's been treating a patient with an anaphylactic shock. Two doses of 0.5 mg IM were given without any improvement. You advise starting on adrenaline infusion. That means you already requested for an adrenaline infusion. While waiting for adrenaline infusion to be started, what is the most appropriate step? So what I told in refractory anaphylaxis, step 1, to start an adrenaline infusion. Do not forget, remember in this manner, step 1, adrenaline infusion. They have already asked, so this one is done. Step 2, what you will be doing? Giving IV fluids. That is not been asked, that's why you are selecting step 2. What will be step 3? If adrenaline infusion is getting delayed, then you can start on or give adrenaline IM 0.5 mg in adults. Every 5 minutes can be given if the delay is more than 5 minutes. Keep on giving every 5 minutes till the adrenaline infusion is started. What is the step 4? Step 4 is to do an ABC assessment where the airway partially obstructed start on adrenaline embolization. In that manner, you will be going ABC assessment. So the right answer here is to start intravenous normal saline. This is what we are in. Step 1, 2, 3. A 66 years old female present to the ED department, facial swelling is present, which has gradually worsened over 6 hours. Bilateral facial swelling with erythema is present. She took paracetamol and ibuprofen for chronic knee pain. Most appropriate treatment. Most appropriate treatment. What are we suspecting here? There is an itching, bilateral facial swelling is present. This is not angioedema. Okay, it's a facial swelling what they are talking about. Okay, it's not an angioedema. You need to pay aware. Angioedema more localized around the mouth, a tongue swelling, what we are looking for angioedema. So this is an diagnosis of urticaria. What do you think might have caused the urticaria here? Recently, she has started taking ibuprofen and paracetamol. So most likely this NSAIDs has caused this an urticaria. How do we treat an urticaria? Mild to moderate, we usually give an antihistamine like Periton. Periton is an antihistamine. Usually they do not give a brand name. Here they are given a brand name. Uh, it is basically it is an chlorphenamine antihistamine easily available on the counter. So you can give them Periton and stop the medication what they are started with. So it's a triggering agent you are stopped with. So this will be the ideal right option. Hydrocortisone, we do not give it in the first instance what they present. Okay, and usually hydrocortisone is in IV form. We like to prefer to give it in an oral form in arterial patients. If the two systems are involved, you are talking about here. Which are the two systems involved? Facial swelling and erythema is still skin is the involvement. System what we are talking about is the skin. Swelling is because of involvement of epidermis. Erythema is the erythema is the red color of the skin. What is involved is skin. So it is one system. Two systems when you are talking about is like a respiratory system and skin. A respiratory system and CVS system. Those are the two systems what we are talking about in that manner. A 77 years old male having an heart racing and feels dizziness, blood pressure is on the lower side. Under conscious sedation, you give first shock. Heart rate and blood pressure remains the same. Okay, doesn't matter what is the rhythm here. Doesn't matter at all because whenever the rhythm is abnormal, we give them a shock. So first shock has already been delivered, not responsive. What we do? We give the second shock. Not responsive. What you do? You give the third shock. Still not responsive. What you give? At that point of time, we think of giving an amiodarone. So first shock is given here. Second shock not yet been given. You need to give. And this patient is not in an cardiac arrest. That's why we are giving an synchronous shock. Cardiac arrest, then it becomes completely different. Sorry. Yeah. The next question is a kid is choking. The kid had a weak cry, hence back blows and abdominal thrust was given. Kid became unresponsive, hence basic life support was started. Patient was intubated with visualization of the endotracheal tube going down the cords. Not able to appreciate chest rise with back mask ventilation or back wall mask ventilation, or basically they are trying to ventilate with the endotracheal tube. The patient is still saturating, desaturating. You have been called for the advice, what you will be doing. So what has happened? We'll consider this as an trachea and it has diverted into it. This this one will be considering as a foreign body. Then we'll be putting an ET tube. So ET tube is somewhere here. The foreign body what you are having is stuck here. It is completely obstructing foreign body. Foreign body is completely obstructing the trachea. Most of the time what we do is we try to push this foreign body. Sometimes it may not be possible to push the foreign body because it is tightly obstructed. What you do in this point of time? We try to do an front of neck access like an tracheostomy. There is a difference between tracheostomy compared to that of a trichothyroidotomy. Tracheostomy, the incision is made around 2 finger breadths above the sternal notch. Whereas for an cricothyroidotomy, you make an incision between the thyroid cartilage and the cricoid cartilage. Okay. If tracheostomy can be done, if you have an ENT available, immediately get a tracheostomy done. So if you make a hole here, he can start breathing. That's why the right answer here will be tracheostomy. What about bronchoscopy? Bronchoscopy is not easy to perform in instant chest physician. Okay, and it is a procedure you may not be able to remove so easily, and it requires a complete sedation. That is not an emergency procedure. What you do it, it's not an emergency procedure. If the patient had an sorry, had a foreign body somewhere here, okay, he's able to breathe. At that point of time, bronchoscopy will be recommended. Severe breathing difficulty. Sorry, paramedics are alerted you for a severe breathing difficulty. Already intubated the patient by the paramedic. The position of the ET tube was confirmed by the anesthetic doctor. Cardiac monitor which shows pulseless electrical activity. What is the most appropriate next step? They are asking. Pulseless electrical activity. Immediately start the chest compression. Once you immediately start the chest compression, next what you'll be doing? Next you will be giving an adrenaline dose. That is a 1 mg adrenaline, 1 is to 10,000 dilution you will be giving to this patient. You make a diagnosis of anaphylactic shock. What is the appropriate site? Appropriate site is mid anterolateral thigh. On the right side or the left side, you can give it, doesn't matter. Mid anterolateral part of the thigh will be the most appropriate answer. You got, sorry, a 24 years old male was involved in a fight, got stabbed on the left side of the chest. Patient didn't have a central pulse. That means cardiac arrest because of a trauma. Stabbing is a trauma. Each part shows fluid around the heart suggestive of a cardiac tamponade. What will be the next best step in the management? So this is a traumatic cardiac arrest the patient is having. If there is a traumatic cardiac arrest, what do we do? We need to follow the different algorithm of the trauma here. So in a traumatic cardiac arrest, if the patient is having a cardiac tamponade, the preferred one is to do a resuscitative thoracotomy, also known as clamshell thoracotomy. So this will be the preferred one. If this was not given in the option, then you can buy some time by doing an pericardiocentesis. But the preferred one is resuscitative thoracotomy. Next one is, in the algorithm, I said that you start the CPR and then you go for airway. If required, you'll intubate the patient in airway and breathing you'll be doing. Then you'll be going into the circulation. In that manner, I had explained to you, where in breathing you'll be doing bilateral finger thoracostomy. Why I'm not doing a finger thoracostomy here? Why I'm not doing or why I'm not thinking of finger thoracostomy? Why I'm not thinking is I already know the cause. If you know the cause, you can directly jump to treatment of the cause. If you do not know the cause, that's when you go in a sequential order where you optimize the airway, then you optimize the breathing, then you optimize the circulation. You'll be going in that sequential manner. As you know the diagnosis already, that's why you're going ahead with a resuscitative thoracotomy. A 21 years old female involved in a road traffic accident, blunt injury from the steering wheel of the car. No central wheel, no central pulse is present. Cardiac monitor shows electrical activity. What is the next step? Cardiac monitor shows electrical activity. It's a pulseless electrical activity because pulse is not present, but electrical activity is present. So it is a pulseless electrical activity. It's a traumatic cardiac arrest the patient is having. So what do we do? In traumatic cardiac arrest also, we start the CPR, then we start looking at airway breathing and try to optimize it. So starting the CPR becomes most important step here again. But remember that at any point of time, if you want to intervene and CPR is hindering your CPR cannot be done because You want to do a certain procedure, then concentrate on doing that procedure in a traumatic cardiac arrest. Do not give importance to the CPR at that point of time. A 29 years old female, 39 weeks of gestation, delivered the baby in the emergency department and no respiratory efforts were seen or appreciated in the newborn. Cover the baby with your tried and cover the baby with an clean cloth. Baby is floppy, fine inflation breaths are given, but no chest trace is appreciated. What is the next best step? If you're not appreciating the chest trace, what you'll be doing? You'll be checking whether the good seal is present or not. If the good seal is present, then what you'll be doing? You will be opening the airway or basically optimizing the airway. Simple airway maneuvers you'll be doing. If that also doesn't optimize, what you'll be doing? 2% technique. If that also doesn't optimize, what you'll be doing? Supraglottic device or ET tube, what you'll be trying to use. A 39 years old female has come in with a lip swelling, has similar complaints in the past and says the usual drug doesn't work. You made a diagnosis of angioedema and administered a 0.5 mg of adrenaline with no response. What is the next best step? What are we thinking about here? We're thinking about an hereditary angioedema in this individual. Usual drug doesn't work. Previous episodes are present here. So it is most likely an hereditary angioedema. In hereditary angioedema, first drug of choice is C1 esterase inhibitor. That is not given here. C1 esterase inhibitor concentrate. What they are given is C1 esterase concentrate. So that is not given. What is the second best choice? To use an FFP. So we are choosing FFP as the right answer. A 39 years old bought by paramedics is in cardiac arrest on arrival to the ED. The patient is having an VF on monitor. One shock is delivered. Core body temperature is 28 degrees Celsius. After 2 minutes of rhythm check, it shows again ventricular fibrillation. What you'll be doing? Core body temperature is less than 30 degrees. Does this change our management or does still can we give the shock or cannot we give the shock? We can still give the shock. First three shocks doesn't matter what is the core body temperature is. Doesn't matter what the temperature is, still you can deliver the shock. So first three shocks doesn't depend on the core body temperature. 6 years old, choking, kid is not responding, central pulse is not felt, or central pulse is felt here, not responding means unconscious. Unconscious kid with an foreign body aspiration, we are suspected, always start with a, ideally start with the infant, ideally start with the pediatric PLS with 5 rescue breaths. 5 rescue breaths is not given. That's why we are choosing start CPR here. Okay, usually it's roughly or very vaguely CPR means giving both chest compressions and ventilations, roughly. Acute onset of rash in an 18 years old female, complains of breathing difficulty. The blood pressure is on the lower side. You suspect an anaphylaxis. Give one dose of 0.5 mg IM adrenaline with no response. Most suitable action to be done. Second dose to be given after 5 minutes. So the most suitable action is to give second dose of IM adrenaline. So first dose of adrenaline as soon as you suspect an anaphylaxis. 5 minutes still not responded. Then what you'll be doing? You will be giving a second dose of adrenaline. Still not responded. What you'll be doing? Ask them to start on adrenaline infusion as a first step. As a second step, IV fluid. As a third step, what you'll be doing? Giving adrenaline IM till the infusion is started. A 78 years old had a syncope. What is the most appropriate action plan? They're asking. Rhythm is SVT, narrow complex tachycardia, regular rhythm, suggestive of an SVT, has a syncope. That is a life-threatening feature. You need to shock this patient. That is a synchronized shock, straightforward question. A patient with anaphylaxis was treated with one dose of 1 is to 1000 dilution adrenaline 0.5 mg IM. Dramatic improvement of the systems was noted. After 6 hours of admission, the patient developed similar symptoms. What advice you give? That means what you will be doing for this patient. The junior doctor has called you and asking for your advice. So what needs to be done for this patient? What he's having is a biphasic reaction. That means he had an anaphylactic reaction, he improved completely, then started having same like an anaphylaxis. You treated same like an anaphylaxis itself by giving adrenaline, starting with first dose of adrenaline, second dose of adrenaline, not responding, refractory shock, then adrenaline infusion, you will be following the algorithm. Recommended adrenaline dose of 1 is to 10,000 dilution to be given in a non-shockwave rhythm to a kid of an 2 years old. 2 years old, we need to calculate the age. Age into 2 plus 8 is the formula. What is the age? 2. 2 into 2 plus 8. That is 4 plus 8. That is 12 kg/Cs. How much do we give? We give around zero point 0.1 ml per kg. What will be giving 1 is to 10,000 dilution. So multiply by zero point 0.1 into 12. This becomes 1.2 ml. So 1.2 ml will be the right answer here. 18 months old kid. The child was having grapes at the daycare center and suddenly became unconscious. During magma's ventilation, no chest rise is appreciated. On auscultation, there is no air entry. What is the most appropriate action? Like I told you, the first slide what we had in the recitation in the part 1. If back mass ventilation, if you are doing it and there is no chest rise is seen, first check the seal. It is similar to that of the newborn life support itself. So you will first check for the seal. If seal is good, optimize the airway. If optimize of the airway still is not there, then what you'll be doing 2% technique. So you'll be following in that manner. So make proper seal with the mask. Check whether the seal is good or not. Risk factors for biphasic reactions. Risk factors, we have already discussed more than one dose of adrenaline. That is the first option, what is there. Previous history of anaphylaxis, no. Previous history of biphasic reaction. Delay onset, not a delay onset, delay in administration of adrenaline. Rapid administration of adrenaline, no. Delay, rapid adrenaline is not a risk factor. Delay of more than 30 seconds, 30 minutes, yes. Age is not related to the biphasic reaction at all. A 60 years old male was brought to the ED department in an ambulance with an episode of syncope, where the heart rate is on the lower side, blood pressure is also on the lower side. The patient takes regular medication, aspirin, bisoprolol, and lisinoprolol. I'm more worried about bisoprolol. Most appropriate next step in management of this patient. Okay, so first thing is bradycardia. Oh, heart rate is on the lower side, bradycardia. Plus, is there a life-threatening feature? Yes, low blood pressure is present. We need to intervene. How do you intervene? We're giving an atropine. So atropine is the right answer. You might be having question now. He's on regular dose of bisoprolol. Regular dose of bisoprolol, yes. But first we give atropine 0.5 mg. If he's not responding, atropine 0.5 mg. At this point of time, we'll be thinking of another drug like an glucagon to be given. If he's not responding because he's on regular dose of bisoprolol. If you change it a little bit, instead of regular dose of bisoprolol, he has taken an overdose of bisoprolol. Overdose of bisoprolol, this becomes a reversible cause. At that point of time, you're giving a glucagon straight away before atropine. How can you confirm a death in a patient? Death in a patient, confirm the identity, assess the response to the pain, assess the pupillary response, palpate for the carotid artery, listen for the heart at least for 2 minutes, and breath sounds for 3 minutes. So only gag reflex we do not check at all. No peripheral pulses, yeah, kind of correct. No breathing efforts, kind of correct. Patient for 5 moments for any kind of correct. Minimum of 5 minutes, absence of central pulse, heartbeat, respiratory efforts on auscultation. This is the most accurate, not completely accurate. Completely accurate is confirm the identity, assess for response to the pain, assess for pupillary response, palpate for carotid pulse, then auscultate heart for 2 minutes and auscultate just for breath sounds for 3 minutes. That will be the most accurate, but that is not given. This becomes the next most accurate option. So we're choosing the option out of the 5 given, which might be the most appropriate one, might not be the best one. 33 years old, palpitations, denies chest pain or shortness of breath, blood pressure is fine, respiratory rate is fine, saturation is fine, best treatment option they are asking. What is the rhythm what we are having? It is a polymorphic ventricular tachycardia. This is also known as torsades pointes. Uh, torsades pointes without any life-threatening features, we treat it with magnesium sulfate. Wife has called the paramedics as her husband develops sudden breathing difficulty. Patient is in anaphylactic shock. Paramedics are given 1 dose of adrenaline. You in the emergency department have given 2 doses of 0.5 mg adrenaline. The patient still in shock, 15 liters of oxygen to maintain 95% of the saturation. What is the next best step in the management of this patient? So what they have done, have we given 2 doses of adrenaline IM? Actually, we have given 3 doses here, not 2, 3 doses. You should have started much earlier about the adrenaline. So this is an refractory shock where you need to start on the adrenaline infusion. So the right answer here is to start on the adrenaline infusion. Not on the IV fluids, adrenaline infusion. You need to ask first for the to start the adrenaline infusion. After you ask for the start of adrenaline infusion, then you think of the IV fluids. 6 months old baby being unwell, having a heart rate of more than 220, 6 months more than 220, it becomes SVT for me. This is a narrow complex tachycardia. Yes, it is an SVT for me unless and until proven otherwise. Blood pressure 90/60, fine, fine for this, fine, fine. Most suitable and so SVT, how do you treat it? If there is no life-threatening features, we do first and vagal maneuver. If vagal maneuver fails, that's when you plan to give an adenosine. 80 years old, swollen tongue, hypertensive, on ramipril for a long time. What is the most appropriate next step? And they are given an image where the tongue is grossly swollen. The first question is, do you think the airway can be compromised in the patient? Yes, definitely. Yes, airway might get compromised or might be getting compromised already here or partially compromised. So airway compromise, I'm strongly suspecting in this individual. If I'm suspecting an airway compromise, it's a severe angioedema. Severe angioedema, I tend to lean towards giving an adrenaline IM 0.5 mg. Your question might be here. Why cannot I think of an ramipril induced drug induced angioedema? If it is a drug induced angioedema, adrenaline will not be effective, doctor. The thing is, I do agree, most likely it might be an allergic angioedema, but we cannot rule out most likely is an drug induced angioedema, but we cannot rule out an allergic angioedema. So, what is a safe bet here? Give an adrenaline and see, because none of the other medications is going to help him acutely here. Okay, for that reason, IM adrenaline is preferred. 90 months old baby, while having food, suddenly turns blue in color. The baby is having seesaw respiration, is unresponsive. What is the most appropriate next step they are asking? They're not commented on anything about the pulse at all. Okay. Is this a normal respiration? This is not a normal. This is an abnormal respiration. Whenever they mention seesaw respiration, it becomes an abdominothoracic respiration. If it is an abdominothoracic respiration, it is an abnormal respiration. If it is an abnormal respiration, what do you need to do? We need to consider this patient to be in the cardiac arrest, start the BLS. Pediatric BLS starts with 5 rescue breaths. So you're giving 5 rescue breaths here. Remember that whenever they mention a seesaw respiration, this is peri-arrest what you are having. Okay, peri-arrest respiration this is. Soon he'll go into respiratory arrest, respiratory failure, respiratory arrest. Soon he'll not have any respiratory efforts at all. A 9 months old complains of a rash allergic to cow's milk. The last meal was 6 hours back. He has a low-grade fever for a couple of days. Mom has given paracetamol for fever an hour back. What is the most likely cause for the rash? And they are given the rash image like this. So it looks like an articarial rash. But the cow's milk, the mom doesn't say he has given. It is 6 hours back, it has fed, but not fed with the cow's milk. Nowhere it says it is a cow's milk. They are just given cow's milk allergy to confuse you. Keeping the history in mind, a fever history plus a rash, if you're thinking it is most likely an viral xanthoma, acute viral infection. It's a viral fever, what is happening. We'll be studying more about this in the pediatric age group. In pediatric chapter and in the dermatology chapter where we'll be discussing about viral xanthomas. A young male brought to the ED department with a penetrating stab injury to the chest. So it is a trauma what the patient is having. Entered to the emergency department, the patient was intubated because the airway was compromised and the patient got arrested 15 minutes before arrival. So this is a traumatic cardiac arrest the patient is having. You continue the CPR in the emergency department, connect to the cardiac monitor, get into large IV bore cannula and start on the IV fluids. What is the next best step? So CPR is ongoing. So we are looking at airway. Airway, I'm not worried because it is already intubated. So tick mark. Next one in breathing. In breathing, what I do an bilateral finger thoracotomy. Okay, finger, sorry, it has bilateral finger thoracostomy. S is missing there. Thoracotomy is just opening, it becomes thoracostomy. It is bilateral finger thoracostomy will be the most appropriate right answer here. After the bilateral finger thoracotomy, if still not responding, then we think of an resuscitative thoracotomy. Resuscitative thoracotomy is not recommended in this situation. Why? Penetrating chest traumas The cardiac arrest should be less than 15 minutes to do it. In a blunt chest trauma, it should be less than 10 minutes to do it. Otherwise, we do not do it. Okay, that is the indications you need to be aware of for for a restorative thoracotomy, also known as clamshell thoracotomy. Which of the following structures are most commonly injured in a Hamlex maneuver? In a Hamlex maneuver, most common structure injured is the ribs. Rib fractures can happen if you do it very violently. Patient had a syncope, has a bradycardia, and has a low blood pressure. That means bradycardia plus life-threatening features. Atropine 3 mg maximum dose here given, but no improvement. What is the next best step? Atropine maximum dose already given, no improvement, transcutaneous spacing. So transcutaneous spacing will be the most right answer here. A paramedic calls you saying that they are getting a patient who is in cardiac arrest. This is the rhythm what you are having. Next best step they are asking here. So cardiac arrest. So it should be an asynchronized shock. Is this a shockable rhythm? Yes, this is a shockable rhythm. It is a pulseless ventricular tachycardia, a shockable rhythm. So you need to give an asynchronized shock. What energy? 150 joules asynchronized shock, what will be giving. So the right answer is option number 4 here. A pregnant lady, 26 years old, she is, deliver the baby in the emergency department. Umbilical cord is cut and the baby is handed over to you. Baby is unresponsive and floppy. What is the next best step they are asking? The next best step is always to call for help. That is not given in the options mentioned here. After that, what we do? Dry and wrap the baby and stimulate the baby. Dry and wrap and stimulate will be the most appropriate. After that, we do an assessment, which they already mentioned here, assessment. Okay, so dry and wrap is important. So remember one trick here. Whenever they mention that, sorry, whenever they mention something in the options, that means that is not done. Okay, they'll not mention in the option which is already been done. If they have mentioned something in the option, that means it is not done. Dry and warm the baby. Have they done it? No, they're not mentioned anywhere. And in the option, they have mentioned it. That means they have not done it. Do that first. Check the heart rate is way below in the algorithm what we'll be having. Okay, it doesn't come here because after this, if there is, for example, this kid is present, then what we need to give, 5 inflation breaths needs to be given along with the chest race is present. If the chest race is present, 5 inflation breath is given, still the baby's heart rate is on the lower side. So it is on the lower down in the algorithm, the heart rate check what comes down. Okay, first check color, tone, breathing, 5 inflation breaths, then heart rate and the chest race is present or not, what you'll be checking at that point of time. 4 months old baby, heart rate is 220. What is the diagnosis? They're asking. So what will be the diagnosis here? It is an SVT because in a less than 1 year old, if the heart rate is more than 220, I will consider as an SVT and the rhythm is also suggested of the same. If the heart rate was less than 220, then I would have considered as a sinus tachycardia. 14 years old, collapsed, systolic blood pressure on the lower side, heart rate is on the higher side. One shock is being delivered. After the shock, the patient blood pressure remains the same and the rhythm is shown as below. So it's a polymorphic ventricular tachycardia. One shock is being given, give more shocks for this patient. So synchronized shock because he is not in cardiac arrest. Asynchronous shock only for the cardiac arrest patients. 15 years old, have peanut allergy and hereditary angioedema. Difficulty in breathing he has come in with. He has, on examination, there is lip swelling and large tongue is noted. Adrenaline is given, but ineffective. What is the next best step they are asking? So what are we suspecting here? Most likely it is an hereditary angioedema. So we need to give C1 esterase inhibitor concentrate. So this will be the right answer. If this was not given in the option, then I would have think of an FFP. Okay, if this also was not given in the option, then I would have think about an bradykinin 2 antagonist. Infant weighing 4 kgs is in cardiac arrest and it is a non-shockable rhythm. What is the most appropriate dose of adrenaline to be given? So it is 0.1 ml. So multiply by 0.1. So it becomes 0.4 ml what you need to give it. What is the dilution? 1 is to 10,000 dilution you'll be giving. So the right answer here is option number 3. A 51 years old female present to the ED department has an lip swelling. On tablet Remipril she is on. Recently she had her wisdom teeth tooth removed and was started on ibuprofen for the pain. What is the most likely cause for the above symptoms? The two drugs which can cause the angioedema. One is the NSAID, that is the ibuprofen, what is present here. Another one is the tablet Remipril, what the patient is on for the hypertension. Which one is most likely? The one which has been recently started. Which is recently started? Recent one is NSAIDs. This is been taken from a long time. So unlikely this, most likely this. So that's why we are choosing NSAID, that is the ibuprofen. This is highly suggestive of an angioedema. 39 weeks of gestation, deliver the baby in the emergency department, umbilical cord is cut and the baby is dried, wrapped in a clean towel, handed over to you. No breathing efforts are seen. What is the next best step they are asking? Have they anywhere mentioned about to call to the help, neonatal call? No. So that should be the first. Call for the help should always be the first step. If they're given in the option, they have not done it. Call it. That is important. Then color, tone, breathing, heart rate assessment comes in. Before that, we need to dry the baby, wrap the baby, then go ahead with assessment of color, tone, breathing, and heart rate. Ambulance has called to a restaurant where the paramedics have found a patient to be in anaphylactic shock. IM adrenaline has been given. On arrival to the ED, the patient only has diffuse urticaria, denies any breathing difficulty. Vital parameters are stable. Next best step. Can we discharge this patient? No, we need to observe these patients. Most of the time, we observe for 6 hours. Fast tracking, the criteria is not mentioned here to really think about fast tracking. So admit for observation for 6 hours is a must here. Stab injury to the chest, clamp cell thoracotomy is performed. Which one of the following is correct? They are asking. CPR to be continued in clamp cell thoracotomy. CPR cannot be done. Okay, CPR cannot be continued. You need to milk it. Okay, that is what has been done here. So this is the wrong option because you open the chest, you cannot compress the directly compress the chest. You need to milk it. CPR is not done. Seventh intercostal approach will give an very better pericardial. No, it is around fifth. If you do in seventh, diaphragm will come up and you may not be able to see the thoracic structures. Cardiac massage is preferred. Yes, this is the milking is known as cardiac massage. Yes, that is the right answer. The horizontal approach doesn't damage the phrenic nerve. Horizontal approach. This is the horizontal incision what you will be having. Horizontal approach, if you have parallel to the heart, you can see the phrenic nerve which is present. Okay, this is the phrenic nerve, left and right side phrenic nerve. Damage of the phrenic nerve can happen if you go in the horizontal approach. Abdominal aortic clamping. You shouldn't be doing. Why you shouldn't be doing an up? There is a descending abdominal aortic clamping. If you do a descending abdominal clamping here, the injury is in the chest. He will bleed profusely and he will die. So it is a contraindicated to do an abdominal clamping if the injury is in the chest. If you are suspecting the injuries in the abdomen and the bleeding is from the abdomen or the pelvis, then you can clamp the descending aorta. 69 years old, complaints of palpitations, life-threatening feature of hypotension is present. Next best step they're asking, you need to just develop you a shock that will be a synchronized shock, straightforward question. Patient has a syncope, low heart rate, enough for me to call it as an bradycardia with the life-threatening features. Full dose of atropine, max dose of atropine, that is 3 mg has been given. You started on transcutaneous pacing, 40 milliampules and heart rate of 70. But there is no increase in heart rate at all. What is the next best step? Keep on increasing the energy, that is the current. So keep on increasing the pacing current here. Presented with the lip swelling as shown in the picture here. Recently, she has removed the wisdom teeth. Ibuprofen she is on, and for hypertension, she is on Ramipril. What is the most likely cause for the above symptoms? We have discussed the same question, but the options are different here. So what we are thinking, it is an ibuprofen. That is an NSAID-induced angioedema, what we are suspecting. What is this NSAIDs? NSAIDs causes pseudoallergenic angioedema. So the right answer here is pseudoallergenic, not drug-induced. If it was a Ramipril, I would have think of often drug-induced. This is not a drug-induced, it's a pseudoallergic angioedema. 5 years old had a biscuit which had walnut. Rash all over the body with breathing difficulty. Now the two systems are involved. Skin is involved here and respiratory system is involved here. In emergency department, you are given 3 doses of IM adrenaline, started on isoprolol infusion. Blood pressure is still on the lower side. Most appropriate next step they are asking. Ideally, what needs to be done? Here, the management is not very well done. Ideally, only 2 doses of adrenaline infusion, IM should have been given. Followed by they should have started on adrenaline infusion. Instead of giving 2 doses, they have given 3 doses. Instead of starting on adrenaline infusion, they have started on an isoprolol infusion. Okay, so what I would have done, I would have changed isoprenyline infusion to an IV, adrenaline infusion. That option is not given here. So what to do? Refractory shock, a infusion, not adrenaline but isoprenyline. They have started. What is the next option? You can give IV fluids. This is where I'm talking. This option is not given at all to choose it. So I'm jumping to the second best option. This is the second best option. Sometimes isoprene might be effective in an anaphylaxis, but that's not the recommendation to use it. A 55 years old is in cardiac arrest. Core body temperature is on the lower side, so it is an hypothermic cardiac arrest the patient is having. Regarding the adrenaline, which one of the following modification of the ALS is recommended for this particular patient who is having and core body temperature of 31 degrees Celsius? You adrenaline every 3 to 5 minutes? Absolutely no. Okay, 3 to 5 minutes if you have to give it, the core body temperature should be much high. Double the duration, yes. Double the duration is the right answer. Should not be given that is less than 30 degrees Celsius. Double the dose, no. Double the duration, not the dose. Reduce the half dose also, no. Only the duration is doubling. The dosage is remaining the same. A 50 years old syncope male was brought to the MS department in an ambulance with an episode of syncope and bradycardia, life-threatening feature. Syncope and bradycardia, life-threatening feature is present. 3 mg of atropine already given. No improvement in the heart rate and blood pressure. Next best step, we already discussed. It is transcutaneous pacing, also known as external pacing. Lip swelling on tablet, bisoprolol and ramipril. On examination, you found out that there is a tongue swelling as well as lip swelling. What is the diagnosis they are asking? This is a classical example of ACE inhibitor induced angioedema, also known as drug induced angioedema. Road traffic accident, the patient has been intubated, no central pulse. That means this is an traumatic cardiac arrest the patient is. The monitor shows asystole. What is the next best step? Airway, intubated already. In breathing, bilateral finger thoracostomy needs to be done. This will be the right answer. Again, S is missing, finger thoracostomy. A 3 years old boy developed shortness of breath. Suspected he must have an aspirated a Lego. There is a weak cry present. What is the next best step? A weak cry is equivalent to an weak cough. Okay, if weak cough is present more than 1 year old, what we'll be doing? We'll be doing an Heimlich's maneuver. Fish should be placed below the sternum process and lower chest during the abdominal. That's how you do it. So if this is the person you are having, you lower him a little bit like this and make a fist just below the sternum and go backwards and upwards. So this is the right option. Holding front of the neck and giving the back blows. This is given for the infants. This is not for the 3 years old child. Let the gravity expel while giving the back blows and thrust. It is the back blows and abdominal thrust what we give it. Gravity, no. We are trying to increase the intrathoracic pressure, not only with the gravity. Fire rescue breath if the patient is unresponsive. That's not the scenario here. Encourage the kid to cough. It's a weak cry equals weak cough. So whenever there is a good cough effort, effective cough is present, then only you encourage the kid to cough. If it's a weak cough, then what you do is you do an Heimlich's maneuver along with the chest thrust. 30, sorry, along with the back blows, not just thrust. The thrust is done in infants. 30 years old, complains of palpitations. In past, she had transient loss of consciousness. In past, blood pressure is normal. All the vital parameters is normal. Best treatment they are asking. Now, what to consider is in the past, the patient had an syncope. Do we consider this as a life-threatening feature or not? No, we do not consider this as a life-threatening feature because it was in past, not in current episode. So the life-threatening feature should be in current episode, not previously. Okay. For example, 1 month back I had a syncope. Now I come in with a palpitation. No life-threatening features as of now. So in this episode, do you have a life-threatening feature? That's how you need to ask yourself while answering the question. So this is a polymorphic VT. Without life-threatening features, we give magnesium sulfate. 4 years old, diagnosis of an anaphylaxis. Most appropriate adrenaline dose to be given for the kid. 4 years old, what you are having. What 4 years old is between 6 months to 6 years. Between 6 months and 6 years, we give 500 mcg. So 500 mcg, also known as 0.15 mg. In any way, they can test you. So you need to be aware of this. A 30 years old pregnant woman at 40 weeks of gestation. She delivers in the emergency department. You notice that the baby is not crying or breathing at all. Drying, wrapping the baby, you are dried and wrapped the baby, and you administered 5 inflation breaths, but there is no chest rise. The heart rate is still on the lower side. Next step. Okay, what next step we'll be doing? We will be checking for the mask whether it is having a good seal. After checking for the mask whether it is having a good seal, we optimize the airway position. That becomes important. Optimize the airway position. After optimizing the airway position, we use an 2% technique. After 2% technique, if still not effective, that's when we do an endotracheal tube intubation. So the problem here is they are not mentioned this step, this step, this step. So we need to choose this step, that is the secure the airway. Yes, that will become the right option here. Not to again give another fine inflation breath. There is no point because there is no this you have to do some interventions. Same thing if you repeat and repeat and repeat again, the results will be same and same and same again. That's why secure the airway becomes the right answer here. 65 years old male brought to the emergency department in the cardiac arrest. The rhythm checked in the ED is and pulseless electrical activity. Wife mentioned that he had experienced chest pain and shortness of breath for few days. Specific treatment should be given during resuscitation. So, what are we suspecting for the cause of the cardiac arrest? We're suspecting a thrombus. What kind of thrombus? Coronary thrombus, what we are suspecting here because of the presence of chest pain and the shortness of breath here. It can be an PE also. Can be a PE. Anyways, it's a thrombus. For any thrombus, what we do? We give an thrombolytic agent. Thrombolysis is preferred. A fibrinolytic agent like an altiplase can be given in during cardiac arrest. So option number 1 becomes the right answer. A 62 years old present to the ED department, sudden onset of palpitations for the past 2 hours, denies any syncope, pre-syncope or chest pain. Vital parameters are kind of stable except the heart rate. What is the most appropriate immediate management they are asking? First, rhythm salvation. The rhythm is irregular without no PVS, first one. And rhythm is irregular, everyone agrees. And this is basically an atrial fibrillation. Along with it, there is an ST segment elevation, what you can see in V2, V3, V4. So it is suggestive of an anterior wall myocardial infarction. So which is the more importance? Here the patient is having AF, but doesn't have any patient is having AF, but the vital parameters are stable. As the vital parameter, I'm checking only vital parameters. I'm not saying it is a life-threatening feature. As vital parameters are stable in this individual, it is advisable that you concentrate the treatment on the underlying cause. The underlying cause here is anterior wall myocardial infarction. For an anterior wall myocardial infarction, the best treatment option will be give aspirin and immediately shift to the cath lab to do an urgent primary PCI. So the right option here is urgent primary PCI because it is an anterior wall myocardial infarction. It is an stenting. That ends the recitative chapter. Anyone has any questions, you can ask me.